support and the role with like malnutrition. So I'll take it away.
Hi, hopefully you guys all can hear me okay. Doesn't sound like the microphone's very loud. No. Is anyone having trouble hearing me? Yes? Okay, I'll do my best to talk really loud. Okay, so thank you for that welcoming introduction. My name is Jenny Martin. I've been a dietitian for a little over 10 years. I have been practicing nutrition support, credentialed in metabolic support for a little over 5 years, and I have been placing feeding tubes for a little over a year now. So let's get started. Real quick, in our scope of practice, the Academy of Nutrition and Dietetics has approved dietitians to place small bowel feeding tubes, which is great, and that occurred in 2012. Also, I just wanted to make note that the state of Missouri has also covered placing feeding tubes under our licensure. Okay, so talking about malnutrition in the CCU setting. Malnutrition is definitely difficult to define and diagnose in the critical care setting. There is difficulty sometimes getting anthropometrics, weight histories, diet histories in this population. Also, stress factors can exacerbate malnutrition and also affect gastric motility and gastric function. There is strong clinical evidence that starting early enteral nutrition can improve patient outcomes, decrease length of stay, and has a favorable impact on patient outcomes. And also reduces disease severity. Those patients with high nutritional risk or existing malnutrition are shown to benefit best from early enteral nutrition. Aspen has defined 2 high-risk screening tools that may be useful in helping us to identify patients who are at high nutrition risk. Some of you may or may not be familiar with these. These aren't routinely used in the hospital setting, but the NRS 2002 scoring system and the Nutrix scoring system have both been used and backed up by randomized controlled trials in Aspen literature. The NRS 2002 screening tool does look at nutrition risk factors, so it does look at weight history, PO intakes, and muscle wasting. The other part of that Nutrix 2002 screening tool also looks at comorbid conditions and severity of illness. The Nutrix scores actually includes a lot more information than that. The Apache 2 scores and the SOFA scores, which actually usually require physicians to calculate those scores and document them. But also in that scoring system, we look at age, we look at labs, oxygenation, if the patient's ventilated, the days in the hospital versus the days in the ICU. We also look at the number of comorbidities and the interleukin-6 score. As these scores are calculated, we can determine if a patient is at low or high nutrition risk. Patients who would most likely benefit from early enteral nutrition are those patients who have a Nutrix score greater than 3 or equal to 3, or NRS 2002 score equal or greater than 3 and a Nutrix score greater than 5. These patients are more likely to benefit from early enteral nutrition. Early enteral nutrition will reduce risk of nosocomial infection, total complications, and decrease risk for mortality than those with low nutrition risk. I also want to make note of our current 2016 Aspen practice guidelines that states that we should initiate early enteral nutrition within 24 to 48 hours in those patients who have existing malnutrition or who are at high nutritional risk. Aspen also recommends that we provide greater than 80% of a patient's calculated estimated energy needs 24 to 48 hours to impact their overall nutritional status and provide a benefit to the patient over their first week of hospitalization. For those patients who are at low risk, Aspen actually recommends that we do not start specialized nutrition therapy within the first week. I know that that might sound a little confusing, as we mentioned that patients are more likely to benefit from early enteral nutrition. However, I want to give you an example of a patient who would be a low nutrition risk, probably on both of those NRS 2002 scores and the Nutrix scores. So routinely, we have patients that come into the CCU with maybe it's a young male who's 28 years old who's come in with a drug overdose. And he had no existing comorbidities, no inflammation, no sepsis, but is on the ventilation to protect his airway. He has no malnutrition, healthy weight, healthy musculature. That patient is at low nutrition risk. So it may actually, in that particular patient, cause more harm to start enteral nutrition than in a patient who is severely malnourished. We want to look at the outcomes or the benefits versus the risks. Okay. Moving on to tube placements, I wanted to mention that anytime a tube is being placed, there are risks, especially for blind placements, which are still being done. Blind placements do increase the risk of a lung placement or a pneumothorax, which causes great illness to the patient. Also, some of the old verification ways of looking at placement of, let's say, a nasogastric feeding tube do lack validity. When we're looking at gastric aspirate, or we're looking at the assessment of the respiratory status or respiratory distress, we're looking at air auscultation, or listening for air auscultation, or looking at the pH measurement of whether it be what we think is sputum or gastric content. There does lack validity and continuity there. So really the gold standard still remains that we use X-ray confirmation for any placement of feeding tubes. This is a picture here of a feeding tube that was actually coiled in the lung and is still in the lung, is not actually in the stomach. What's nice about the machine that I'm going to talk about, the CoreTrack machine, is that we are actually able to see, not this is an X-ray, but we're actually able to see looking at fields, whether we are in the lung or stomach, so we can hopefully prevent these type of situations, these lung placements and risk of pneumothorax. Okay, I'm going to talk a little bit about the advantages of gastric tubes, but I'm more importantly going to talk about the advantages of small bowel feeding tubes and cover just a few maybe cons of small bowel feeding tubes, or things that we do have to consider when we're placing small bowel feeding tubes. So Aspen does report that changing the level of infusion from the stomach to the small bowel has shown to reduce the incidence of pneumonia, aspiration, and regurgitation. I do want to note that in 2016, the Nutrition Clinical Practice Journal did also add that placement of small bowel feeding tubes does improve nutrient delivery and increases our ability to get tube feedings to goal rate. But I also want to mention that there is no difference in mortality, ICU or hospital length of stay, duration of mechanical ventilation, or time to goal of EN, that's still kind of debatable, with gastric versus gastric versus small bowel feeding tubes. Some advantages of gastric feeding tubes is that it can decrease the risk of a clogged feeding tube. Usually those gastric feeding tubes are larger bore feeding tubes, so we can deliver medications more easily. Another advantage of a gastric feeding tube is that when we feed gastrically, it favors or it resembles that of normal digestion and normal hormonal regulation. Some risk factors for gastric intolerance. That would include a patient that's ventilated or has sepsis or severe illness. We do know that gastric motility or gastroparesis is more common, or gastric motility declines in patients who are critically ill. Also, sedatives and paralytics that are more commonly used in the critical care setting can also further delay gastric emptying and cause GI intolerance. Increased NG outputs and severe illness also, again, increase risk of gastroparesis. Looking at aspiration risk factors, I want to cover those real quickly. Risk factors would kind of be similar to those things that increase gastric intolerance. And again, that would be someone who's on the vent or has neurodeficits, has a decreased level of consciousness, is in the supine or laying flat position, has an advanced age or already existing GERD or gastroparesis. So ways we can overcome risk of aspiration and improve gastric feeding would be when we can elevate the head at least 30 degrees, use continuous infusion of enteral nutrition, chlorhexidine mouthwash, BID. We can still aspirate on oral secretion, so keeping the bacteria down by using chlorhexidine improves or decreases the risk of aspiration. Using prokinetic agents like Reglan or erythromycin can enhance gastric motility in these patients who already have poor gastric motility. And then last, divert the tip of the feeding tube post-pyloric, which is going to lead us into talking more about small bowel feeding tubes. So this is our CoreTrack enteral device. This is what it looks like. The device or the monitor shows the placement of the feeding tube. The blue triangular piece actually lies on the patient and picks up the signal from the feeding tube as we're placing it. The CoreTrack enteral device does address patients whose risk factors cannot be reliably done with blind placement. So if a patient has an abnormal anatomy, for example, we've placed a feeding tube in a patient and luckily we're able to see it going into the lung, but the patient had no signs of intolerance of us placing that feeding tube into the lung. Luckily, we're able to pull back and remove the tube, but in a blind placement, a nurse could easily continue to advance that feeding tube into the lung and cause more injury to the patient. So that patient didn't cough, the patient didn't have a decrease in O2 saturation, or show signs of distress. So again, this is one of the benefits of this access device, is that we can see that and hopefully prevent lung placements. The CoreTrack does provide real-time visualization of the feeding tube placement and does provide 3 images for us to better assess the placement of that feeding tube. The dimensional display screen also can challenge, this is a 3-dimensional screen, it can also challenge x-rays. The CoreTrack enteral access device does focus on an acronym called SAFE, so I'll cover that real quickly. SAFE basically means that we can provide this compact, portable unit for immediate visual feedback of the tube tip relative to the position of the tube in the patient using real-time display. Also, we can have confidence in avoiding adverse reactions such as lung placement and pneumothorax. We can also better visualize precise gastric, duodenal, or jejunal placement. We can reduce the need for x-rays and re-verification with continuing x-rays. And we can provide immediate recognition of errors while we're placing the tube, like I mentioned in the patient that wasn't showing any signs of a lung placement, but we were able to see that and pull the tube out. So the track correlates with x-ray to help identify misplaced avoid adverse events. Also, the depth cross-sectional view, which we'll talk about, again, challenges X-ray, and so it's definitely a very accurate view if the user is very accustomed to seeing that view and interpreting it correctly. This feeding tube placement can be faster and than placing it sometimes on waiting for the patient to move to a surgery unit for an endoscopically placed feeding tube or a feeding tube being placed under fluoroscopy. We can just do it at the bedside. And then usually we're waiting for a blind placement. Sometimes we're waiting for the nurse to become available to place the feeding tube. And as a dietitian who can advocate for placing the tube and place the tube, we can make all of those steps happen a little faster. And last is economical. Basically, the FDA has cleared the stylet, which I'll show you guys a quick video, but has cleared for us to re-stylet a feeding tube. If there's any questions on if the tube has become dislodged or misplaced, we can re-stylet that feeding tube when we're hooked up to the machine and get a view of where that feeding tube is, or correct the placement of it and avoid hopefully more x-rays or harm to the patient than if they were having a blind tube placed. There's also those additional cost savings if we're able to avoid the tube being placed under fluoro or endoscopy, which has to require a radiologist or a surgeon to place those tubes, and obviously those are expensive. Okay, so a little bit on how the tube works, and then we'll watch the real quick video. But this is an electromagnetic signal that is sent from the transmitter at the distal end of the feeding tube stylet to a receiver that's placed on the patient at the xiphoid process. This corresponds to the base of the diaphragm as the patient is lying supine. The signal is then triangulated, and the tip of the styleted feeding tube is tracked on a portable monitor as we're watching the tube being placed. The device provides an anterior, lateral, and three-dimensional view, which again improves accuracy. Okay, so we'll watch a real quick video here.
Tube coming in down the esophagus.
Oh.
This is off to the right a little bit,
Okay.
but it has a very
Hold on,
nice
just a second.
straight line and a good.
The person that knows how to get the video on the screen.
Kyle.
I tried it earlier, but I thought she purposely left it where. Thank you. Okay, we're ready. Sorry.
Down the esophagus. This is off to the right a little bit, but it has a very nice straight line and a good curve in the stomach, so you can feel confident that you're not in the lung, as long as the patient's not coughing. On the left-hand side, on the depth cross-section, you can see that it's trying to go through the pylorus, as well as on the anterior view. Right now, you're probably feeling a lot of resistance as you try to put the tube in, so you should just stop and let the pylorus take the tube through it. It's probably the hardest thing about putting feeding tubes in is being patient and not pushing the tube when the body doesn't want it pushed. here you can see that this patient likely has very good peristalsis. That ball is moving nicely within the stomach. Some good questions to ask before you put the tube in so you have an idea as to whether or not this will go smoothly is if the patient has been being fed, the patient is having regular bowel movements, just to get an idea of whether or not they've got good GI motility before you even start. Right now this tube is sitting in the pylorus trying to go through it. You can see that in both views. It's going through the pylorus. This tracing could be a little bit confusing. There's not a great C-curve and it barely crosses midline and comes back, but because of that depth and just the position of it, it is too deep to be in the stomach. And if you look at it anatomically, it follows the line of the stomach through the small bowel, likely at the ligament trace on X-ray. And I think the depth cross-section is most helpful when you're at the pylorus because you're seeing it going down. If you look at it later on in the tracing, you might get confused and think that that's coiled up in the stomach the way that it looks. So you really want to be looking at it at that point where you think you're hitting the pylorus is where it gives you the most information.
And I'll better explain these views to you in just a minute.
On this abdominal film, the X-ray again matches the core tracing except at the end where the tube has migrated farther into the duodenum.
Okay, I just wanted to show that quick video so you guys
You can see the tube coming in down the esophagus.
Okay, you guys could see the real-time visualization that we see when we're placing the tube. Okay, great. So these are the views that I wanted to point out here. Okay, so over to this slide here, the first picture is actually a lateral view. That's where the tube is kind of making a smiley face there. That lower part of, is there a way I can get the red? Maybe just not pushing the right thing. Perfect. Okay. So this is the view I was talking about. This is our lateral view. This is as the tube's going in, you'll see it follow the natural anatomy of the esophagus. Sorry. Okay. Follow the natural anatomy of the esophagus. As the esophagus lies more posterior, then you'll see the tube come up as the stomach lies more anterior. Also, this is the lung. View here. So if at any time this tube goes far up, that would show that the tube is curving and going into part of the lung. As the tube crosses this axis here, that axis is kind of known as the lower esophageal sphincter. So as you move through the esophagus and come up to the stomach, you know you've passed the lower esophageal sphincter, you've moved more anterior into the stomach, and then you see the drop as the small bowel is also more posterior, lines up with the esophagus. Okay? This is the anterior view, which you guys saw in the video as the tube's dropping, and this looks more like normal anatomy here. This is the depth cross-sectional view. This is the view that's most advantageous to us. Anytime X-ray reads the tube as being coiled or questions if the tube is crossed the midline, we can provide a printable view right from the machine and show that to the radiologist and show that the tube has crossed the midline and has come down into the small bowel. So that depth cross-sectional view, you can't get that on X-ray. So that's one of the good advantages to this CoreTrack device. Okay, so the patients that we include for, or the patient for small bowel feeding tubes, and it can be any of these things here, are patients who have high aspiration risk, which we've covered ways to decrease aspiration risk, but at any point a physician feels that the aspiration risk is too great to the patient, they already have been on the ventilator for several days or have compromised clinical status as it is, it's best to err on the side of caution and decrease that risk by putting the tube further down post-pyloric. Any patient that has severe gastroesophageal reflux disease or esophagitis, also patients that have altered anatomy of the esophagus or stomach, we can see the tube being placed, so that's always more advantageous. Any patient that has recurrent refractory emesis, has failed gastric feeding, so this would be a patient that has routinely showed intolerance to tube feeding or has high gastric residuals. Patients with acute pancreatitis where the physician does not want to use gastric feedings and wants to use jejunal feedings. This is helpful because we can place the feeding tube to the fourth portion of the duodenum or to the ligament of Treitz. Multiple trauma or prolonged post-surgical patients, and patients who are on paralytic agents or who have severe delayed gastric emptying. Some contraindications for using the CORTRAC device. This is patients who have elevated PTTs or INRs, so patients who are at very high risk of bleeding. While that tube is very flexible and soft, it does have a stylet through it, which is a wire that is put through the tube that picks up the electromagnetic placement. And so that tube can become a little stiffer, and if the patient is at high risk for gastric bleed or nosebleed, we want to be careful. So we do kind of look at those labs and usually make sure the doctor's okay with us placing it, even if that PTT and INR is a little elevated. Any patient who has current or chronic history of severe epistasis or nosebleeds, obviously placing a tube in their nose may cause an uncontrollable nosebleed, which would cause more discomfort and potential harm to the patient. And that usually kind of correlates with a patient who already has a really high INR or really thin blood. Any patient that has facial trauma or fractures, the tube sometimes, if they've had multiple trauma or fractures, the tube cannot follow sometimes the normal anatomy, and so the tube may go up towards their eyes or towards their brain, to parts in the face, so we don't want the tube to go in. So that's always a good question to ask the patient if they have history of that, or try to get a good interpretation if there's any risks there. Also last, patients who have active implanted devices. Because the electromagnetic signaling from the CORTRAC device can interfere sometimes with pacemakers or AICDs, defibrillators, so usually we want to make sure we try to avoid placement in those patients. It can be done, but usually I make sure the physician is aware. Okay, last, how do we secure this feeding tube to make sure all the work we've done doesn't change and the patient still has a feeding tube that can hopefully remain in place? So we secure these feeding tubes with what's called the nasal bridle. We know that NG feeding tubes can routinely become dislodged. We also have patients that are at risk for pulling feeding tubes out. So anytime we can more accurately secure these feeding tubes, the better it is for the patient. The less interruption of enteral nutrition and the better outcome the patient has from getting enteral nutrition. Looking at these nasal bridles, there was a study in 2014 also in the nutrition clinical practice journal that looked at nasal bridles versus adhesive tape. And this study showed that displacement rates are as high as 62% with just adhesive tape. That's where we're taping the feeding tube right below the nose, or we're taping it to the face. Adhesive tape does cause discomfort to the patients, can cause skin tears, breakdown, allergic reactions to the tape, interfere with the endotracheal tubes, but more importantly, can interfere with BiPAP masks, the masks that go over the face and have a really tight suction. So unfortunately at our hospital we had some inappropriate uses of TPN. Patients that were pulling out feeding tubes and we didn't have any way of securing the feeding tubes other than tape. We didn't have nasal bridles. We also didn't have we didn't have a way to provide feedings to a patient that needed post-pyloric feeding access. We didn't do endoscopically or fluoroscopically placed feeding tubes. So we had a higher incidence of TPN, or inappropriate TPN. So as a CCU dietitian there, I heavily advocated for this CoreTrack device and the nasal bridle so we can decrease the risk of inappropriate TPN and provide those benefits that I mentioned to the patient with early enteral nutrition and gaining adequate nutrition through the enteral route. So what I wanted to mention was that those feeding tubes, when we have the BiPAP on and the feeding tube was being secured with tape, that created a leak in the BiPAP mask. So that was another patient population that was getting inappropriate TPN because the BiPAP could not remain on their face with the feeding tube in the way. So now that we have the bridles, and now that we have the small bowel feeding tubes, we can put patients on tube feeding who are on the BiPAP and avoid inappropriate TPN. Also, a lot of physicians like for us to use post-pyloric feedings in patients who are on BiPAP or on vents and aren't stable, patients who may need to lay flat, they're not hemodynamically stable either. These small bowel feeding tubes are very advantageous in those situations. So one other really quick little video is to show you how these nasal bridles are placed, and yes, we place those too in addition to the feeding tubes.
The AMT bridle nasal tube retaining system was developed to help avoid the high cost of nasal tube pullouts while simultaneously improving patient outcomes. The bridle is easily placed by passing magnets within the nasopharynx, which allows umbilical tape to be looped around the vomer bone and then anchored to the tube with a clip. The AMT bridle system.
I wanted to mention, I didn't know how many of you caught that, but obviously the way that the bridle provides a more secure placement and helps patients from confused patients or agitated patients from pulling out their feeding tube is again that umbilical tape goes behind the vomer bone, which is pretty far back in the nasal cavity. So anytime the patient starts to pull on that tube, it feels like a severe brain freeze. So naturally they would stop pulling on it. The only patients that we don't recommend putting the nasal bridle in, sometimes it's difficult in patients with deviated septums or broken noses. Still can be done, but it can be more challenging. But really it's for those patients that don't feel any pain. Maybe they have severe psychosis where pain is not really going to affect them, so they can still pull that feeding tube out. Okay, like I mentioned, at our hospital, we did have some inappropriate use of TPN. So I wanted to cover real quickly the appropriate uses of parenteral nutrition, and these come from our ASPEN 2016 practice guidelines. So patients with low nutrition risk, we should really reserve from using TPN until after the first 7 days of CCU admission. Really, the risk to the patient outweighs the benefit in someone who does not have a high nutrition risk or is not severely malnourished. patients can't meet PO intake, or enteral nutrition is not feasible, this is when we're referring to using TPN, because obviously there's still criteria for using TPN as well. Patients determined to be at high nutrition risk or who are severely malnourished, and when EN is not feasible, the guidelines do go ahead and suggest that we start TPN right away, so we have more benefit to the patient at that point than risk. And patients either at low or high nutritional risk who need supplemental parenteral nutrition, they should only be considered for this supplemental parenteral nutrition 7 to 10 days after they've proven to not meet at least 60% or greater of their estimated energy needs by the enteral route alone or by the PO route. Okay, in summary, as a dietitian at Cox Medical Center Branson, we don't need a metabolic support team. We're not large enough for that. So as a dietitian, I feel very strongly that we can take on this job of placing small bowel feeding tubes. And so I want to mention that it's our job to assess and correctly select the right patients for gastric versus small bowel feeding tubes, advocate when needed for small bowel feeding tube, advocate for against inappropriate TPN use, and then go ahead and just place those tubes, right? So the training for the feeding tube placement actually isn't too difficult, and there is training that's done by the CoreTrack representatives that help us obtain this training, and we do pass little tests regarding the training, and then also we apply the knowledge and are signed off on competencies to prove how competent we are in placing the feeding tube. So when RDs are trained and credentialed to place these post-pyloric feeding tubes, there is an improvement in nutrition support initiation, delivery of enteral nutrition, ongoing therapy. We can avoid nursing placement delays, which I'll talk about here in a minute, decrease the use of inappropriate TPN, and improve patient outcomes. So one thing that I've noticed is we do have some critical care charge nurses who are trained to place small bowel feeding tubes. But one thing I've noticed and why I'm passionate about the RDs placing feeding tubes is that there is a delay in when that nurse can get to placing that feeding tube. If she's a charge nurse and she has patients or phone calls, other things to do, unfortunately the placement of that feeding tube comes last. And so we may wait hours or all day for that tube to be placed, and then we leave before it's placed, or while it's being placed we leave and x-ray reads the x-ray to confirm placement, and we don't see that till the next day, and then tube feeding may not get started till the next day. So one way around that is sometimes we go ahead and order the enteral nutrition upon confirmation that that tube is placed in the small bowel. But other times, some physicians aren't crazy for that, and so we have to wait till the next day. So there can be delays in starting enteral nutrition. Also, I don't feel that nurses have a real good understanding sometimes, at our facility. If it's on the metabolic support team, it's a different situation, but at our facility, I don't feel like they have a good understanding on which patients are appropriate for gastric versus small bowel feeding tubes. Also, that it's a very patient procedure, and sometimes if the nurse does find time, I feel like they're rushed to get through it as they're getting phone calls or paged, and so it takes away from the patient care. If the dietitian is able to obtain the order from the doctor, get everything ready, go place the tube, have radiology call them and put the tube feeding order in, we can rearrange our whole day's patient load around this feeding tube placement, and then see our patients, before, after. So basically we can work it into our workload better. And the dietitians at our facility, we've placed actually the majority of the feeding tubes and have done so successfully. So I feel very excited about that, and I encourage other dietitians to maybe take on this role at their facility if they're able to, or advocate for a CoreTrack machine. There's lots of evidence out there that shows the benefits of it. And I just want to summarize or leave on a note of saying that we need to continue to be the nutrition champions for all things nutrition, even if that means getting in there and placing a feeding tube. Thank you guys very much, and I hopefully I left a few minutes for a few questions. Did I? No, maybe not. Okay, well, I'll do. Did I?
We have one more presentation at the end of this.